Okay, guys, do we have everyone back? I get see some 16 members here. So I think that's pretty much we have a good number. So this will be a review. That's a reason it should be interactive, right? So what I'll do is I'll unmute you guys and I expect you to answer as well. So try to keep the background noise as minimum as possible. Okay, can you hear me? Yes, and the screen is visible as well, right? Okay, so we'll first start with revising the different diseases. I'll give you different scenarios, and you have to tell me what abnormality of sex differentiation are we talking about. Okay. If you have a larger sheet, you can put all these diseases in one sheet, but I don't have space here, so let's do one by one. So first of all, identify what's the problem. Genetic is female, gonadal is female, internal female, so everything is female. External, she had labia clitoris. So to begin with, it was female. But why do you think there was hypertrophy of the clitoris? She was a female to begin with. But later, why did her clitoris get enlarged? Because she got exposed to excessive androgens. So what type of hermaphroditism are we talking about? Correct. Female pseudo-hermaphroditism. Correct. Because genetic and gonadal, she is female, but her external characteristics, she developed hypertrophy of the clitoris. She may have developed hirsutism. She won't have her menstrual cycles. She will have amenorrhea. So these are all virilizing characteristics. So that is female pseudohermaphroditism. What are the causes? Give me a disease where androgen production increases, adrenal androgens. Congenital virilizing, adrenal hyperplasia. What's the enzyme defect? 21 or 11 beta hydroxylase deficiency. Good. Or in a mother who was pregnant and she was carrying a girl child, for any reason, if the child got exposed to excessive androgens. Next, what are we talking about? 45XO, Turner syndrome. So you can tell me the features. Okay, Turner syndrome, she has no Y at all. So to begin with, her gonad should be ovary. What should happen to her internal external? She has no testosterone and all that. So internal external has to be female to begin with. But it's also called as gonadal dysgenesis. So ovary is not fully functional, it's rudimentary, due to which she will not have enough estrogen. Because of that, will she get her menstrual cycles? No, she will have amenorrhea. Plus, because she has less estrogen, generally these patients are short. And what are the other congenital defects they will also have? Neck, what happened? Webbing of neck, webbed neck. Plus, they will also have shortening of the fourth metacarpal bones. Plus, they will also have congenital heart disease, kidney disease, etc. What's the other chromosomal defect we looked at? 47XXY. What was that? Klinefelter's. So no need to memorize. You can derive it. So in Klinefelter's, there's a Y chromosome. So to begin with, they have to have testis. Their internal external has to be male. But it's called seminiferous tubular dysgenesis. Their testis is not fully functional. Therefore, the testosterone levels will be less. Their sperm count also will be less. Because of that, these individuals also will have infertility. Plus, their testosterone level is less. Therefore, at puberty, what will happen to them? Can the testosterone cause male-like changes? Can the testosterone, its amount is very less. For male-like changes, you need lots of testosterone. They don't have enough. So what's the tendency if testosterone is not getting used up? It will get converted to what? So they will have more and more formation of estradiol. And who does this conversion? Which enzyme? Aromatase, which is found in the adipose tissue. So in these individuals, the testosterone is not getting used up. So adipose tissue aromatase converts it to estrogen. So they will have feminine characteristics. So give me some feminine characteristics. They'll have breast enlargement. Good. Gynecomastia. And body structure will be like that of females. Broad hips, fat distribution like that of females. And their extra X chromosome, they will have more chances of having mental retardation. Next, so what happened here? Chromosome was XY. But why testis was not formed? For testis formation, what did the male need? Anyone? SRY gene was required. So maybe probably this male did not have SRY gene. So by default, what will happen to their gonad internal external will be female. What hermaphroditism will you still call this? It is still male. Good, because go by the chromosome. First and foremost, you have to go by the chromosome. Chromosome is XY. So this would still be male pseudohermaphrodite. And why did they not have testis? There was absence of SRY gene. Okay? You guys good? Guys, you're with me, right? Yeah, okay. Because review, it should be engaging. No, it's a bit weird. Okay. Next, did I write 47 there? Sorry, it was 46XY. What did I write there? Sorry, 46XY. Okay. Gonad was ovary and internal external was female. Okay, I apologize. So it was 46XY. Gonad was ovary, internal external was female. So why their gonad was ovary despite of it forming testis? It should have formed testis, right? Because they did not have SRY gene. So this is would be an example for male pseudohermaphroditism. Sorry, it was 46XY. And if it is 46XY, we will still call it as male pseudohermaphroditism. If you see any mistake, please correct it. I didn't even pay attention to that number. So it's 46XY. Okay. Next, 46XY, testis, seminal vesicles, vas deferens, uterus, cervix, fallopian tube. They had penis, scrotum. What happened here? So that's why you have to identify internal, external. So you have to know which structure accounts to what. Okay. Now here chromosome was XY, gonad was testis. They had seminal vesicles, vas deferens, uterus, cervix, fallopian tube. They are all internal. So they had both male and female internal. And their external was male. So what do you call this individual? Again, it is male pseudohermaphrodite. And what was the problem here? Why did they have both male and female internal? Because they did not have anti-Mullerian hormone. So which cells were defective in the testis? The Sertoli cells were defective. They did not have AMH. Because of that, they had both male and female internal. So it's one of the causes for male pseudohermaphroditism. Good. 46XY, testis, internal was none. External, they had vagina ending as a blind . 46XY, testis, internal was none. External, they had vagina ending as a blind . 46XY, testis, internal was none. External, they had vagina ending as a blind . 46XY, testis, internal was none. External, they had vagina ending as a blind . 46XY, testis, internal was none. External, they had vagina ending as a blind pouch, gynecomastia. Okay, what are you thinking about? So Leydig cells are defective, due to which they did not have testosterone. Their AMH was working. So what happened to the Mullerian duct as well? It got regressed. So internal was none and external was female. Yeah, that's one possibility where the Leydig cell. This is again a cause for male pseudohermaphroditism because chromosome is male. One possibility is yes, they did not have testosterone and because of that their Leydig cell was defective. But I've given you gynecomastia, right? So gynecomastia means there was some amount of testosterone secretion, but since it did not get used up, it got converted to estrogen. So what's the other defect we spoke about towards the end? Yeah, one what you told is correct. Testicular feminization, or otherwise called as androgen insensitivity syndrome. So what is androgen insensitivity syndrome? What's the problem there? Testosterone and DHT receptors are not working. So if testosterone and DHT receptors are not working, what's going to happen? The testosterone cannot work. AMH is okay, so internal will be none. DHT receptors are also not working. So tubercle, swelling and fold form the female external. But at puberty, what will happen to the testosterone levels as such? So it was a Leydig cell defect means we would not worry about that conversion. Here, think about at puberty, testosterone is increasing. But because the receptors are not working, it has tendency to get converted to estrogen, giving rise to testicular feminization syndrome, feminizing characteristics. So they will have gynecomastia, etc., but they don't have menstrual cycles because they have no ovary. So this is how questions are asked. You'll be given the structures and based on that you have to tell. Let's do the last one. So what happened here? Again, chromosome is male, so it is male pseudohermaphrodite, where internal was male, only male. Why was the external female? What did they not have? They did not have DHT. Good. And that means 5-alpha reductase deficiency. Why was there hypertrophy of the clitoris? Only their DHT is not working. Testosterone is okay. So at puberty, what will happen to the testosterone levels? It will increase. So their external was female to begin with. So the clitoris got overstimulated by the testosterone and it will enlarge. So what's the other name for the 5-alpha reductase deficiency? You call it as penis at 12 syndrome. That means clitoris is enlarging. Not that they're developing an actual penis. So that's the hypertrophy of the clitoris. So do you get the hang of how to do these questions? You list out what are the structures given to you. You decide whether they are internal or external and based on that you will answer. Any questions on sex differentiation? Guys, yes or no? You're okay? Okay. Now moving on. Yeah, typically in a class I would have given you this quiz, given you time to work on it and then discussed. But now because of time constraint, we'll discuss the slide, discuss the hormone and things associated with that hormone. Are you ready? So let's look at this kid. And what are we talking about? The child is short for his age. And what could be the possible cause? So what are the possible causes? Sorry. Okay, so what is the possible causes for dwarfism in endocrinology? Which are the possible hormones which can give rise to dwarfism? Growth hormone deficiency and thyroid hormone deficiency. Why do you tell this child is not thyroid? It has to be growth hormone deficiency we are talking about. Correct. The body proportion is according to chronological age, whereas in thyroid dwarf, body proportion will be infantile. Plus, if you look at hypoglossal weakness, not exhibited. If there was protrusion of tongue, hypoglossal weakness in a thyroid dwarf, what does that indicate? Mental retardation. This child has not got any protrusion, so that means no mental retardation. So that's why your most likely answer here would be growth hormone deficiency. The child has growth hormone deficiency. And the next question was, what are the differences between a thyroid and pituitary dwarf? Thyroid dwarf will have mental retardation and infantile body proportion. Pituitary has chronological age, body proportion according to chronological age, no mental retardation. Next, if a child is short, growth hormone is less. On giving GHRH, if growth hormone increases, where is the problem? They are responding. So the anterior pituitary is not the problem. So where is the problem? Hypothalamus. Despite giving GHRH, if growth hormone is less, so there when is the problem? Anterior pituitary. What cells secrete growth hormone? What is the name of the cell? Somatotropes. They are acidophilic or basophilic? Acidophilic. So if there is an acidophilic tumor of somatotropes, growth hormone will increase. Before puberty, what do you call that disease as? Gigantism. After puberty, what will you call that disease as? Acro. What's the main difference between gigantism and acromegaly? Before puberty, if it's high, what will happen to their height? Very tall. Acromegaly may not be very tall, but they'll have other cartilaginous proliferation. What's protrusion of jaw called as? Prognathism. Plus, why do these individuals in growth hormone excess have gynecomastia and galactorrhea? Good. Why do they have gynecomastia? Because growth hormone is structurally similar to prolactin. Why do they have bitemporal hemianopia? We are talking about excess, so it has to be a tumor we are talking about. So what is that tumor compressing? Optic chiasma. There's compression of optic chiasma giving rise to bitemporal hemianopia. Next, growth hormone is less, IGF is less, GHRH has increased. Where is the problem? Growth hormone is less, so that's the problem. We're talking about deficiency here. So anterior pituitary is the problem. Because of that, IGF decreased and hypothalamus tries to correct it. Now here, look at what has happened to IGF and growth hormone. So we're talking about excess. Where is the tumor? GHRH itself is high. So the tumor is in the hypothalamus. Good. Where is the lesion? No, hypothalamus. Why you went to thyroid? It's still growth hormone we're discussing. So where was the lesion? By the hypothalamus. Okay, that's fine. Next, GHRH is high, growth hormone is high, despite which IGF is less. So the baby is short. Good. Laron receptor is not working, and that is Laron dwarfism, where the GH receptors are defective, due to which IGF cannot be generated, child is short, and your hypothalamus and pituitary tries to compensate by increasing the hormone. Good. Give me a cause for Panhypopituitarism, but anterior pituitary is not working. In a lady, what is that disease? Sheehan's. So what was Sheehan's? What was the connection? Why in pregnancy the anterior pituitary enlarged? It was preparing her for childbirth. So which is the first hormone which got stimulated? Prolactin, due to which what happened to her lactotropic activity? It increased, due to which her anterior pituitary got enlarged. And it depended on a good vascular supply, right? It depended on a good vascular supply. So what happened if she developed postpartum hemorrhage during pregnancy? She developed hypovolemic shock, good, which affected the vascular supply, anterior pituitary necrosis. So going along these lines, so tell me what happens to FSH, LH, TSH, prolactin, ADH. So what happens in Sheehan syndrome? All the anterior pituitary hormones will decrease, including prolactin, because lactotropes are necrosed as well, but posterior pituitary ADH will be spared. If you see FSH, LH less, growth hormone less, ACTH less, but prolactin has increased, then where is the problem? It should mean a stalk lesion or hypothalamic lesion. So what happened to all the releasing hormones? They decreased. So that's why all the other hormones decreased. And why did prolactin increase? Because there was no dopamine. Coming to prolactin, if I'm telling you lady is secreting prolactin from first trimester, does she lactate from first trimester? No, right? So what is action of estrogen? Estrogen stimulates the lactotropes to secrete prolactin. But what does it inhibit? It holds on to it till the right time. It inhibits the synthesis of milk proteins. So it won't allow it to act. Once the baby is born, estrogen is withdrawn and then prolactin starts working. So this is the basis for one of the diseases we discussed. Do you remember? Neonatal breast discharge and enlargement. Do you remember this? A newborn baby. Why did the newborn baby present with breast enlargement and discharge? It was not a disease. It was because of mother or the maternal estrogen. So maternal estrogen crossed the placental barrier and stimulated prolactin secretion in the baby, due to which after the baby was born, when estrogen was withdrawn, the inhibition of milk protein was lost and prolactin starts working. So it will cause neonatal breast enlargement and discharge. You don't have to do anything because there is no further estrogen stimulus. So eventually what will happen to all of this? It goes back to normal. So the main reason for neonatal discharge was maternal estrogen causing secondary increase in prolactin in the baby. But after that, there's no more estrogen stimulus. So prolactin will decrease and come back to normal. What is this? Identify the clinical disorder. Albinism. What's the enzyme defect here? Tyrosinase. Good, good. Tyrosinase, which converts tyrosin to pigment. So in tyrosinase deficiency, there's no pigment production. Because of it, leads to hypopigmentation and albinism. Which hormone has MSH-like activity in humans? ACTH. Why? Because they're structurally similar. So what was the precursor from which they are derived? Pro-opiomelanocortin. Good. And because of that, they're structurally similar. In which disease ACTH increased, giving rise to hyperpigmentation? Addison's disease. So I think there's another question on Addison's. We'll discuss Addison's there. This person is tall, so it has to be what? Gigantism, which is growth hormone excess before puberty. Okay, because tall stature has to be gigantism. Whereas if he had prognathism, protruded forehead, etc., it would more likely be acromegaly. Person has gynecomastia because of excess of prolactin. So if prolactin is excess, what's the tumor called as? Prolactinoma. And what will be the clinical features in this person? Gynecomastia, galactorrhea, and male impotence. And if it's female, they will present with amenorrhea. What is lactational amenorrhea? No menstrual, break the two words. Amenorrhea is no menstrual cycle during lactation. Why? Start with why. During lactation, which hormone increased? Prolactin, which will suppress GnRH, that will suppress FSH, LH. Which hormone can stimulate prolactin secretion, resulting in amenorrhea? Stimulate. Oxytocin, yeah, during suckling reflex, we want to maintain prolactin. So yeah, oxytocin can stimulate. Which other hormone can increase and stimulate prolactin? TRH. So any thyroid disease, if they are telling you amenorrhea, you have to relate it to TRH, which stimulates prolactin and causes amenorrhea. Why during stress there is amenorrhea? Post-traumatic stress, lady presents with amenorrhea. So stress means which hormone will you associate it with? Cortisol. So what's the connection? What suppressed during stress? What was the regulatory hormone for cortisol? CRH. So during stress, what happened to CRH? Increased. So that will suppress GnRH, FSH, LH, and there was amenorrhea. You got this? So if I'm asking you about lactation, associate with prolactin. Anything to do with thyroid, if I'm asking you, associated with TRH. Anything to do with stress, if I'm asking you, which hormone should you associate it with? Increase in cortisol, but go to the higher level where it regulates. So increase in CRH will downregulate GnRH, FSH, LH. So these are the different endocrine causes for amenorrhea. What drug will you give to treat prolactinoma? Give me the drug. Dopamine agonistic, name it. Good. Bromocriptine. So the drug used to treat excessive prolactin will be dopamine agonistic drug, bromocriptine. Okay, what's this lady exhibiting? Marked feature here is atrophy of breast and male type of pubic hair growth. So we are talking about virilization. So what's the disease we are talking about? Congenital virilizing adrenal hyperplasia. Enzyme defect would be the 21 or 11 beta hydroxylase deficiency, due to which what happens to aldosterone level? Aldosterone will decrease, cortisol will decrease. So what will happen to pregnenolone? It forms excessive androgen. Which is more severe, 21 deficiency or 11 beta? 21, because if we don't have 21, even the precursor weak mineralocorticoid is not there. Whereas with 11 beta deficiency, at least you have the weak mineralocorticoid. Because of that, she will have virilizing characteristics, plus aldosterone is less. So what can happen to blood pressure? Decrease, sodium decrease, potassium and H plus increase. Good. What does 17 alpha hydroxylase give rise to deficiency? All the 17 derivatives cannot be formed. And who is dependent on the 17 derivatives? Cortisol and androgen. Therefore, all the precursor goes and forms excessive aldosterone. So here androgen is less, cortisol is less, aldosterone is high. So if androgens are less, now in sex differentiation we did this, right? These androgens are source for testosterone in the male child. So this child will have less testosterone. And if the child has less testosterone, it's a genetic male, but they will have less testosterone. So what will happen to their internal? Guys, just, yeah, if something is running, just mute it, please. Guys, just a kind request. There's some video running at the background. Can you please mute it? Because this is a review. If I don't get a answer, I don't know what I'm doing. Appreciate that. Okay, let's go back. Yeah, so 17 alpha, androgen was less. Now in sex differentiation we did, if androgen is less, the testosterone reservoir will be less. So what will happen to their internal? They have less testosterone, but their AMH is fine. So internal will be none. And external, if they don't have enough testosterone, external will be female. So 17 alpha hydroxylase can give rise to male pseudohermaphroditism. Plus, aldosterone is high. And what's the disease where aldosterone is high? What do you call it as? Cons. So we'll revise cons here. Tell me about cons. Too much aldosterone. So sodium will increase, blood pressure will increase. Because of that, the blood pressure is high. What happens to the RAS mechanism? It gets suppressed. So what will happen to renin secretion? Suppressed. What will happen to potassium and H plus? Excreted. Metabolic alkalosis. Even though their sodium and ECF volume is high, you don't see edema. Don't find edema. And what's that phenomenon called as? You're not seeing edema, aldosterone escape. So what was causing aldosterone escape? Anyone? ECF volume increased. Therefore, what will happen to venous return? And what will that release from the right atrium? Good. Atrial natriuretic peptide. And because of an increase in ANP, sodium and water got lost. Not fully, not 1:1. Some amount of sodium and water got excreted. So the hydrostatic pressure did not change significantly. So they don't have edema. That's the aldosterone escape. Good. This guy, what's very obvious? Protruded brow, prognathism. So we're talking about acromegaly. And visual field defect I already told you, because acromegaly means growth hormone excess. We're talking about a tumor which is compressing the optic chiasma. Is it an acidophilic or basophilic tumor? Acidophilic tumor. Good. Okay, tell me about this individual. Most obvious feature is moon face pot belly. So what are we talking about? Cushing's, cortisol excess. Clinical disorder is Cushing's due to cortisol excess. And let's discuss the dexamethasone suppression test. What would have happened to the dexamethasone suppression test? So let me revise this as a whole. So start with, sorry, I'm just figuring out how to get a blank sheet here. Okay. Okay, let's talk about Cushing's. Is this visible, the screen? Okay. So in Cushing's you have syndrome and you have disease. Syndrome means what's the cause? It's primary. So cortisol by itself is high, and due to negative feedback, what will happen to ACTH? Decreases. Disease is secondary, where ACTH is the problem, excess, due to which cortisol is high. So problem for cortisol increase would be an adrenocortical tumor or exogenous administration of cortisol for treatment purpose if somebody is getting too much dose. Disease where ACTH is the problem, anterior pituitary tumor And what's an ectopic cause for ACTH? Carcinoma of the lungs. So based on this, you can do the dexamethasone test. So in dexamethasone suppression test, we measure the baseline ACTH and cortisol. We give low dose 1 milligram or high dose 8 milligram dexamethasone at night, and next morning we repeat the values. So based on your test results, what do you infer from this? So that is the inference. Okay. So this is inference or the diagnosis. So this stands for diagnosis. So with a high or a low dose, of dexamethasone, our ACTH and cortisol is getting suppressed. So what's it? That's a normal response in you and me. High or low, H and L stands for high and low. High or low, your ACTH is getting suppressed, but cortisol fails to get suppressed even after you repeat with the high dose. That means it's an aggressive tumor secreting cortisol. So where is the tumor? Primary adrenocortical tumor. Next, when you give a low dose, ACTH and ACTH is not getting suppressed. So obviously cortisol won't. But when you repeat with the high dose, it's able to suppress ACTH and cortisol. So it has to be an ACTH tumor on the axis which is less aggressive. So where was it? Anterior pituitary. Good. Last one. High or low does not matter. Your ACTH was not at all getting suppressed. So cortisol also remained high. So this has to be a ACTH secreting tumor not on the axis. What was the source? Carcinoma of the lungs. Good. So the question was, what is the response to dexamethasone test if cause for the disease is secondary? Secondary means they're talking about an anterior pituitary tumor. So there you had got a biphasic response. With low dose, ACTH would be high, cortisol also would be high. But when you repeat the test with the higher dose, what will happen to ACTH and cortisol? They get suppressed. Okay. Primary means adrenocortical tumor. Low dose or high dose does not matter. Cortisol continues to be high. What are the clinical features of Cushing's? Why is the pot belly moon face seen? Because of excessive fat. Cortisol is high. So what will happen to fat? Lysis. Because cortisol increases sugar, breaks down protein and fat. There's muscle wasting, fat lysis and formation in an abnormal manner, giving rise to redistribution of fat. What can happen to bones in Cushing's? Wasting. Osteoclastic activity increases, resulting in osteoporosis. What's the action of cortisol on blood sugar? It's hormone of stress. It increases your blood sugar by mainly stimulating gluconeogenesis, right? What is its function on glycogen? It's called as a permissive action. This is a hormone which increases sugar. It should have broken down glycogen. But what does cortisol do? It stimulates glycogen synthase and forms glycogen to help which hormone? Glucagon, because glucagon is dependent on the glycogen reservoir. So it's called as a permissive action by which it facilitates glucagon to act unopposed. Okay. Next one. What is this called as? Adrenal medullary cells are pheochromocytes. So what's the tumor of adrenal medulla called as? Pheochromocytoma. Give me clinical features. Exaggeration of fight-flight response. So what will happen to fight-flight response? What happens during fight-flight response? Start from the top. You have to be awake. Pupil will dilate. So in pheochromocytoma, there's excessive pupillary dilation, resulting in poor vision, blurring of vision. What will happen to heart rate? Increase. Palpitation, blood pressure, increase. Hypertension, and whatever sympathetic like effects will get exaggerated. So all the P's: perspiration, sweating, poor vision, palpitation, pressure increase, pheochromocytoma. What's the urinary test you do to suggest too much of catecholamines? Increased urinary levels of vanillyl mandelic acid indicates there's too much of catecholamines generated. Name a drug which inhibits the sodium iodide pump. Perchlorate, thiocyanate. Drug which inhibits peroxidase enzyme. Propyl thiouracil, methimazole, carbimazole. Drug used to treat palpitations. Beta blocker. What was the drug? Good. Propranolol. So read the question carefully. If they are asking you to treat palpitation, give propranolol. But if they are asking you to treat hyperthyroidism, you have to give any of these drugs. When we do radioactive iodine uptake, if this is the normal uptake, anything which is higher is increased uptake, lower would be decreased uptake by the thyroid gland. Increased uptake means what will happen to urinary excretion? Decreased. Decreased uptake by the gland means what should happen to the urinary excretion? Increase. So here the excretion will decrease. So I will tell you, give me whether it's A or B. Thyroid adenoma, A or B. So how do you identify this? If any disease where the gland activity has increased, it is A. If the gland is suppressed, B. Thyroid adenoma, gland activity has increased, A. Good. Graves' disease. What has happened to the gland activity? Antibodies are stimulating, like TSH, stimulating the gland. So what will happen to the uptake? Increased. Exogenous T3, T4. Your blood levels, and why do we take exogenous T3, T4? Most commonly abused in the form of weight loss supplements. They present with hyperthyroidism. But it was because of exogenous supplements. What happened to the hypothalamic pituitary thyroid axis? Got suppressed. Therefore, what will happen to the uptake? Even though they are hyper, their uptake will be less. Hashimoto's, what happened to the gland? It was destroyed. So what will happen to the uptake? Less. B. Endemic goiter. Basically, they had iodine deficiency. So think of it like that. They did not have iodine. So what happened when you gave radioactive iodine? The uptake will increase. Uptake will increase. It will be A. What's the diagnosis here? Exophthalmos, goiter. Exophthalmos and goiter. So what's the disease? Graves' disease, where autoimmune reaction, antibodies are structurally similar to TSH, due to which T3, T4 will increase. Will this person have goiter? Yes. But because of negative feedback, what happens to TSH levels? Decrease. And again, what will happen to the radioactive iodine uptake in this person? It will increase. What's Hashimoto's? It's again autoimmune, but here thyroiditis, right? So what do these antibodies do? They cause thyroid gland inflammation followed by scarring, due to which what happens to thyroid peroxidase levels? Depleted. T3, T4 levels will decrease. Radioactive uptake also will be less. They don't have a typical goiter, but they might have a diffuse swelling, but not a typical goiter. Whereas endemic iodine deficiency, T3, T4 is less, TSH will increase, the structural integrity of thyroid gland is okay, so it will enlarge and they will have a typical goiter. And what will happen to the radioactive uptake? Gland activity has increased, so what will happen to the uptake here? It will increase. So in Graves, TSH level will decrease. So if I tell you T3, T4 is less, TSH has increased, TRH has increased. Where was the lesion? Thyroid gland is the problem. Will they have goiter? Yes, provided the gland is intact. So in endemic iodine deficiency, will they have goiter? Yes. But in Hashimoto's, it's unlikely. Okay. So depending on the response of the gland, they may or may not have goiter. Will they have prolactin-like symptoms? TRH is high. So will they have, so whenever I ask you prolactin-like symptoms, what are they? Gynecomastia, galactorrhea, amenorrhea. So will they have amenorrhea and prolactin-like symptoms associated with TRH? TRH is high. So will they have? Yes. T3, T4 is high. TSH and TRH is less. Where is the problem? Tumor. Thyroid gland has a tumor. So will they have goiter? Goiter is enlargement of the gland. If there is a tumor, there will be a goiter. TRH is less. So will they have prolactin-like symptoms? So they don't have prolactin-like symptoms. Where is the problem? You're talking about excess. See what has happened to the primary hormone. Excess means tumor. Where is the tumor? Anterior pituitary. Will they have goiter? Yes. Will they have prolactin-like symptoms? No. Good. Everything has increased. So where's the tumor? Hypothalamus. Will they have goiter? Yes. Will they have prolactin-like symptoms? Yes. Where is the problem? We're talking about anterior pituitary is not producing. TSH and T3, T4 will increase. Hypothalamus tries to correct it. Here, um, which disease we covered where anterior pituitary is suppressed? One is Sheehan's. Tell me what's craniopharyngioma. Tumor on the stalk, which is suppressing both the anterior and posterior pituitary. So what will happen to all the flat pig hormones, including prolactin? Everything is suppressed. Don't worry about dopamine. The lactotropes are suppressed because of the tumor, right? So even prolactin will decrease, and posterior pituitary ADH oxytocin also can decrease because the tumor is compressing both the anterior and posterior pituitary. So that's how, based on hormonal profiles, you should be able to tell where is the problem. Based on the thyroid gland activity, you should tell whether there's goiter or not. Based on TRH, relate with prolactin-like symptoms. So when you do TSH stimulation test for hypo, on giving TSH, if T3, T4 increases, where is the problem? T3, T4 increases. So where is the problem? It cannot be the thyroid gland. So where is the problem? You're giving TSH, so there is anterior pituitary issue. In spite of TSH, if T3, T4 does not increase, problem is with the thyroid gland. Repeat with TRH stimulation, same concept. But since it's this TRH, you have response of two things to look at, TSH and T3, T4. So if it was an anterior pituitary problem, on giving TRH, what should have happened if there was an anterior pituitary problem? When you gave TRH, will the anterior pituitary respond? No. So TSH and T3, T4 continues to be less. If the problem was with hypothalamus, when you gave TRH, what should happen to their TSH? Increase, and based on that, what will happen to T3, T4 as well? Increases. If thyroid gland was the problem, on giving TRH, what would have happened to TSH? Increase. But what happened to T3, T4? They continued to be low. Good. So that's with Graves' disease. Hyperpigmentation. So what are we talking about? ACTH excess seen in primary adrenocortical insufficiency, and the name of the disease would be Addison's, because ACTH has MSH-like activity. So in primary insufficiency, what will happen to cortisol, aldosterone, and androgen? All the three are less. ACTH is high. Because of that, they have hypoglycemia, aldosterone deficiency effects, lack of axillary pubic hair growth. And the main feature is hyperpigmentation. What is the response to ACTH stimulation test? On giving ACTH, if it is primary, what should have happened to cortisol? Will the adrenal gland respond? No, the disease is in the adrenal glands. So even if you give ACTH, will the adrenal gland respond? No. So what should happen to cortisol levels? It should continue to be less. So responsible for hyperpigmentation is increase in ACTH because it's structurally similar to MSH. What will happen to blood pressure in this patient? Cortisol, aldosterone is less. So blood pressure is low. And what's the response to ACTH stimulation? The adrenal cortex is not working. Cortisol continues to be less. Now compare this with secondary insufficiency. In secondary adrenocortical insufficiency, there's no specific name. Anterior pituitary is the problem. ACTH will be less. So this individual will not have hyper. It's not this case. In general, I'm asking about the other one. There is no hyperpigmentation. Cortisol and androgen is going to be less. What do you think happens to aldosterone in secondary insufficiency? Anyone? If ACTH is less, there's a secondary increase in angiotensin 2. So that will get the aldosterone levels back to normal. So in secondary insufficiency, aldosterone is not affected. So sodium, blood pressure, etc. remains normal. Potassium and H plus levels also remain normal because their aldosterone levels are regulated by angiotensin 2, and this angiotensin 2 keeps their aldosterone levels at normal. So that's how you differentiate. And what's the response to ACTH stimulation test? So in secondary insufficiency, when you give ACTH, what will happen to cortisol? Their anterior pituitary was the problem. So when you gave ACTH, cortisol will increase. Good. Okay. What's this child having? There's protrusion of the tongue. So the child is having mental retardation. What's your diagnosis? Hypothyroidism, cretinism in the child. If it is deficient in an adult, what do we call it as? Myxedema, because the most important clinical feature is severe edema all over the body. And what type of edema is it? Non-pitting edema due to accumulation of proteins. In the child, there will be mental retardation and infantile body proportions. That is cretinism. Shortening 4th-5th metacarpals, cortisol excess, positive Archibald or dimpling sign. What's the diagnosis? Albright's hereditary osteodystrophy, where there's a defect in G protein, due to which what happens to cyclic AMP levels? Decreases. PTH cannot work. So what will happen to serum calcium? Decrease. Serum phosphate will increase. And due to a feedback mechanism, since calcium is less, what happens to actual PTH levels? Increases. So that's why the disease is also called as pseudo hypoparathyroidism. So in this patient, if you give injection PTH, will they respond? The problem is G protein. So even if you give PTH, will they respond? No, cyclic AMP levels continue to be less. I'll give you the table for PTH. This is a picture of leg of patient with infective non-healing ulcer. So what are the possible endocrine causes? Glucose is high. diabetes mellitus, or cortisol excess as well, because any disease where sugar is high and immune system is suppressed. So in diabetes and Cushing's cortisol excess, blood sugar is high, and what has happened to the immune system as well? It is suppressed. But most likely it is diabetes because the sugar is very, very high, and this high level of sugar is usually seen in insulin problems. So that is diabetes mellitus. Basis for this is high sugar and immunosuppression. So I'll post this quiz, okay, and you can just go over it. Before we leave, let's do the PTH table. Okay, so this is PTH levels, cyclic AMP level, serum calcium, phosphate, urine phosphate. The previous one was serum phosphate. Next is urine phosphate. PTH is high, cyclic AMP is high, despite which calcium did not increase much. Phosphate remained in the blood, failed to get excreted. So when you see this combination, despite PTH increasing, why did calcium did not increase significantly? Because the only site which was available for it to compensate was the bone. Where do you come across this situation? What's the diagnosis? Where the kidney is gone, vitamin D is less. That would be chronic renal failure. So in chronic renal failure, because of vitamin D deficiency, why? Which enzyme could not be activated? 1-alpha hydroxylase. Due to which serum calcium was less. Even though PTH increased, it could only act on the bones. And because of renal failure, the filtered load was less. So serum phosphate increased, urine phosphate decreased. PTH is less, despite which cyclic AMP is high. Serum calcium is high, serum phosphate is less, urine phosphate is high. What do you think? Despite PTH is less, all the features of hyperparathyroidism is seen. Second messenger also has increased. It has to be someone who's acting as an imposter for PTH. Who's that? What is it? Yeah, breast cancers, paraneoplastic syndrome, true. So it's because of whom? PTH related peptide, usually seen in paraneoplastic syndrome like carcinoma of the lung and the breast. So that's what giving you a clue. Someone is acting like PTH, and that someone is increase in PTH related peptide. PTH is high, cyclic AMP is high, calcium increases significantly, phosphate decreases, urine phosphate increases. That means PTH has all the sites to work, and that would be a parathyroid adenoma. So what's classical features in hyperparathyroidism? Hypercalcemia can give rise to renal stones, nephrocalcinosis. And what's the effect on the bones? How does PTH work? It first binds to osteoblast, stimulates cytokine release. That stimulates osteoclast and results in osteoporosis when in excess. If PTH is less, cyclic AMP will also decrease. Serum calcium will decrease. Serum phosphate increases. Urine phosphate decreases. So that means parathyroid gland itself is the problem. And what's the most common cause for parathyroid damage? Thyroidectomy, accidental damage. Good. So here if you give PTH to the patient, will they respond or not? They did not have PTH. So if you give PTH, will they respond? Yes. So what will happen to cyclic AMP levels in blood and urine? Both will increase. PTH is high, despite which cyclic AMP is less. And the other features will be similar to this. What did this tell you? Even though PTH is high, their calcium is less, phosphate is high. That means it's not able to act. So where is the problem? G protein or the receptor. So what's the disease? Albright's hereditary osteodystrophy, otherwise called as pseudo hypoparathyroidism. So in this condition, even if you give PTH, even if you give injection PTH, what will happen to their cyclic AMP levels? It continues to be less. Okay, that's about PTH. Which hormone increases calcium, decreases blood phosphate? Which hormone is this? Crashes the phosphate. So which hormone? PTH. So how does it trash out the phosphate? It inhibits phosphate reabsorption in the kidney at which site? P for P. It inhibits phosphate reabsorption in the PCT and stimulates calcium reabsorption on which segment? Early distal convoluted tubules. Good. What does which hormone increases both calcium and phosphate? Vitamin D. So if it is deficient, what will happen to calcium and phosphate levels? It will drop. What's vitamin D deficiency in child known as? Rickets. Clinical features of rickets: bow leg, knock knee, frontal bossing, rickety rosary. In adults, give rise to osteomalacia. Because the solubility product becomes less, the bone gets demineralized, cannot be mineralized, weakening of bones. Which hormone decreases both calcium and phosphate? Calcitonin, secreted by parafollicular cells of the thyroid gland. What does it do to osteoclastic activity? It's decreasing your blood levels. She does not want to take it from the bone, so it inhibits osteoclastic activity. In a person who is on space flight mission or who is on prolonged bed rest or immobilized, which cells do not get stimulated? No mechanical stimulus, suppresses blast, clast takes over, due to which there's mobilization of calcium and phosphate. Therefore, what happens to serum calcium and phosphate levels? Increase. If serum levels increase, what will happen to filtered load as well? Increases. Therefore, what will happen to urine calcium and phosphate levels as well? Increase. Calcium is already high, so which hormones will it not want? So it will inhibit. And what will happen to PTH and vitamin D levels? It will decrease. Which hormone can help? Calcitonin. So calcitonin levels will increase. Hypocalcemia results in a disease called as tetany. What are the clinical features? Increase in neuromuscular excitability, due to which they present with the hand, no, it goes in for spasm. That's called as carpopedal spasm. So some patients may only have perioral tingling and numbness. They don't have proper carpopedal tingling and numbness, so they won't have carpopedal spasm. What are the two signs you can elicit? If it's subclinical tetany, you want to elicit the sign. So what are the two signs? Chostek's, tap the cheek, look for facial contraction. Or the other one is Trousseau's sign, where in Trousseau's sign, what are you doing? Wrap the BP cuff, inflate the cuff, and look for carpopedal spasm. Why a person who hyperventilates presents with tetany or carpopedal spasm? Start from the cause to the effect. What was causing this hyperventilation? So what will you relate it with? CO2 drop. pH becomes alkaline, and this alkaline pH ionizes proteins which carry negative charge, and they go and form complex with positive calcium, due to which eventually what will happen to free ionic calcium level? Drops, resulting in tetany. How will you treat? How will you treat? Inhale CO2 by doing paper bag breathing. Okay, guys, this is the best we could do in this limited time. I didn't give you a break, so I like, is there anything else you want to ask? I'm unmuting you guys. Do you have any questions? Yes? Okay, if not, I'll try to see if I can get those two recordings for review of endocrinology, which I did chapter wise previous semesters, and I'll post it in the recorded Panopto lectures. Please go through the lab recordings I have put down, uploaded on your Moodle practical file. For the ones who didn't attend the first half, I was just telling that under your practical physiology folder, go to PowerPoint on respiratory system examination. First slide has two links. It's a very nice link telling you how to examine and the different lung sounds. Make sure you go through it. Spirometry, refer to the class notes. And if we get some information about exams and everything, you'll be notified. But in between, if you have any questions, feel free to shoot me an email. Okay, so I think I've concluded my topics. So I know it was a very rough semester, but we had to do what we can. And in one way, this helps you to face with the real world out there. Like medicine, it's emergency. You have to deal with different situations in that given moment. And thank you to your class. You are really very resilient. You have cooperated with us really well, and I'm thankful for that. Okay, good luck, guys. And if anything, just shoot me an email. You're most welcome. And from tomorrow, Dr. Anirudh will start his class. Okay, okay, guys, stay safe. If anything, shoot me an email. All the best. Yes, yes, yes. You're free. You're free because Dr. Anirudh will just start his lecture at the regular time slot. Okay, so I just added one session for today. You don't have any other links to join in. But if at all Dr. Ani needs later for the next week, you can let him know that biostats is free. Okay, so you can finish your topics earlier. Okay, yeah, Carmen, you can just coordinate with Dr. Ani and let him know. Okay, okay, guys, stay safe and thank you so much for all your cooperation. It was indeed a pleasure teaching you guys. Bye.